Today I would like to talk a little bit about public health in the age of globalization. And as many of you know, this year actually marks the 10th anniversary of the Sars outbreak of 2003. Well, India itself was not much affected by this, but it was a very significant problem in several parts of the world, including China, Hong Kong, Singapore, Taiwan, and Canada. And even though it was largely confined to these countries, the fear and economic impact of SARS was global. I won't really talk about SARS or its containment, but it does teach us one very important thing, and that is the rapidity with which it spread. The World Health Organization actually issued its global alert about SARS on 15th of March, the Ides of March. And as this map shows, by 6 weeks later, by the 29th of April, there were already more than 5,000 cases of SARS in many countries around the world. So the SARS outbreak, I think, was a very dramatic demonstration of the speed and extent of interconnectedness of our world today. And if one thinks about it, it is a function not just of the fact that both people, goods, animals, and services are traveling much more quickly and much more broadly than ever before. It's also a function of the way globalization has driven economic development in many countries around the world. So specific to this point, if one thinks about how the increasing pressure on land because of economic development brings humans into contact with places where in the past humans were not. And this increases the risk of transmission of diseases from wild animal populations there to humans. At the same time, animal husbandry practices in many parts of Asia, particularly in China, Indochina, and Indonesia, often see humans being brought into very close contact with poultry and other animals. And this again increases the risk of transmission of diseases from animals to humans, and therefore increases the risk of epidemics. But it's not just that our world is much more interconnected in extent and speed. It's also related to a much greater degree of complexity. We are now living in a highly connected and complexly interacting world. So if I just follow the illustration that I used earlier, if one thinks about a broad label of globalization drivers, by which I mean factors which increase economic development, societal change all around the world, then one very critical factor has been the rapid economic growth in developing countries. And this, as I will discuss later, is leading to what is called an epidemiological transition. At the same time, rapid economic growth in many countries is leading to environmental degradation. And the public health implications of this are an increase in environmentally related diseases such as pollution-related diseases, diseases associated with soiled and contaminated water, and also a greater exposure of workers to work-related types of diseases. Then, of course, all of us know that economic development has all around the world led to widening income gaps. And this, from the public health point of view, has important implications. For example, it puts pressures on access to healthcare because of barriers of costs. So health financing can create barriers and create 2 or 3 track systems where the poor and the migrant populations may not have access to essential healthcare. Now, of course, I've shown this in a linear way, but we know that it's not actually linear. It's in fact fiercely interactive. And so one can draw additional arrows. For example, widening income gaps can result in increased people movement, and people movement can increase income gaps. In particular, rural to urban migration, which is a very important feature in India, in China, and many parts of Southeast Asia, can actually exacerbate the work-related types of diseases because they create large migrant populations, often in slums in cities, who don't have proper access to water, who are exposed to occupational diseases and also sexually transmitted diseases. Also, these large migrant populations in cities can result in an exacerbation of health financing challenges and reduce access of these populations to healthcare. So one can actually develop this ad infinitum, and this is a slide one of my good friends, Paul Zimmet, shared with me. It is a slide, a simplified slide, showing the interactions between social factors and obesity. And you can see that there are arrows running everywhere. So complexity is a feature of globalization and its health. And the key point I want to make with these illustrations is that health, social and economic development interact in many complex ways, something which I refer to as the tangled web of health. The tangled web of health. So with this as a backdrop, I think an important question for those of us living in Asia is, how are the effects of globalization playing out in public health in Asia? How does this affect us here in Asia? And I think, as all of you realize, we need to understand that Asia is a very heterogeneous geography, it's a very heterogeneous set of countries. And this heterogeneity can be seen in many ways. Here I just show some summary data. If you look at GDP per capita, we have countries like Laos, and then all the way ranging to a country like Japan, where the GDP per capita is nearly 30-fold greater. And as a consequence of this marked difference in GDP per capita, the total health expenditure also varies very markedly. So if you look at the figure in Laos, it's $39 per year, and in Japan it's almost 100-fold higher. So this drives a lot of differences in the ways that the health systems are set up and are able to respond to challenges. Well, for big countries like India and China or Indonesia, in fact, the regional differences in healthcare and public health parameters may be greater than the inter-country differences that we see within Asia. So here's just an illustrative example. If you look at life expectancy, you can see that in a number of countries, provinces in China, that if you look at a place like Shanghai or Beijing, the life expectancy is fairly similar to countries like Singapore and Korea. But if you look at a place like Tibet, their life expectancy is closer to that of Laos and Myanmar. So this heterogeneity within a country can be as vast or even greater than that across countries in Asia. So Asia is extremely heterogeneous, but Asia is also in the midst of massive and accelerated change in terms of public health. And if you think about the way rapid economic growth, through globalization in particular, about its impact on critical aspects of the way societies are organized and work in Asia, what we are seeing, of course, is major trends in increasing urbanization. We see this particularly in China and in India. And with urbanization, you have all the issues of high-density living, as well as a great deal more rural-urban migration. Then we have very fundamental social changes in lifestyles, in diets, in education, and all these have a very important impact on public health. I spoke about widening income gaps, which have themselves very important influences on health availability, and of course environmental degradation. So if you think about the end result of the interaction between all these different factors, then we can think about Asia as being in the midst of a series of concurrent transitionings happening at the same time. So Asia is undergoing a very major demographic transition. It's undergoing a massive nutritional transition. It is undergoing a very accelerated epidemiologic transition, and is also undergoing a very significant health system transition. So let me just touch briefly on what each of these transitions entail. So in terms of the demographic transition, the really critical things that are happening in Asia are low fertility in some areas, very rapid rural-urban migration in others, and aging in yet other countries. So if you look at fertility, many countries in Asia have fertility rates which are below replacement. So some examples are shown there: Japan, China, Korea, Taiwan, Singapore, and Thailand. It's only in a few countries such as India, Cambodia, Laos, and Philippines where total fertility rates are above replacement. At the same time, several of our countries in Asia are aging rapidly. So this slide shows the current population above 65 in the blue bars, and the projected population in these countries above 65 by 2025. And you can see that countries like China, Singapore, Japan, and also countries like Korea, Hong Kong, and Taiwan will be experiencing very, very rapid and fundamental aging of their populations. And this, of course, has very profound effects on public health and the provision of healthcare services. Well, beyond the demographic transition, Asia, as we all know, is undergoing a tremendous nutritional transition, moving away from traditional diets which are low carbohydrate, low calorie, high carbohydrate, low fats, very quickly to the high total fat, high refined sugar, high refined carbohydrate types of diets, which combined with sedentary lifestyles has fueled a massive epidemic of obesity. And added to this, now we have what is termed an epidemiological transition. That is a high and rising prevalence of communicable diseases like hypertension, diabetes, heart disease, and cancer, a high and rising prevalence of these in countries which still have a very significant burden of communicable diseases. And added to this, in several of these countries, there's also the ever-present threat of emerging infectious diseases of epidemic potential. So in fact, Asia, or some parts of it, are thought to be the likely hotspots for future epidemics of the future, including South China and parts of Southeast Asia, are thought to be the sites where the next SARS infection epidemic might emerge. So this epidemiologic transition is a very severe one. And in the next couple of transparencies, I want to just highlight a few features of them. The first is, if you look at this table, which shows the burden of disease as shown by disease-adjusted life years per 100,000 population, and you look at these countries, illustrative countries shown there, the first point is that the burden of non-communicable diseases is actually very high across all the countries, regardless of whether they are developing or developed countries. And if you look at Laos and China, for example, their burden of communicable diseases remains extremely high, even though the non-com diseases have increased significantly in prevalence. So if you look at Southeast Asia, for example, this slide shows in a very dramatic way the influences of this phenomenon. If you look at the red bars, they show the mortality from infectious diseases, and the blue bars show the mortality from non-communicable diseases. And I think you should note 2 points from these slides. First, even in developing countries like Laos and Cambodia, more people die from non-communicable diseases already than from communicable diseases. In other words, non-communicable diseases like diabetes and hypertension used to be thought of as diseases of affluence, diseases that occurred in rich countries. That is no longer the case. And you will see that the burden of non-communicable diseases, as shown in the blue bars, is actually larger in developing countries like Cambodia and Laos as compared to more developed countries like Singapore or Brunei. Actually, the greater burden sits in developing countries. And the implications of this are that these systems are going to be exposed to a double burden of disease, which they are not usually able to cope with well. And I think the bad news is that as these countries get richer, the prevalence of non-communicable diseases will further increase. So for example, this is a plot showing the prevalence of diabetes on the y-axis and the per capita income on x-axis. And if you look at the extreme right of the curve, Singapore and Brunei have the highest per capita income, and of course they have the highest prevalence of diabetes. Whereas countries like Cambodia and Laos and Vietnam are at the bottom end on the left side. But the implications are that as these countries get richer, their burden of diabetes and other non-communicable diseases will further increase. And it means really that not only will the burden high today, it will be set to grow even higher in the future. So these sets of forces, the heterogeneity of Asia and the fact that Asia is in the midst of very massive and accelerated change, result in many major driving forces and implications on healthcare systems. I think the bottom line for both high-income and low and middle-income countries in Asia is that all these factors will conspire to drive up demand for healthcare in the future. In the high-income countries, the burden of non-communicable diseases, rapid aging, as well as the people looking for higher and higher quality and overconsumption of healthcare, these are the things that will drive up demand. In low and income countries, you have this growing epidemic of non-communicable diseases, a high infectious disease burden, and also increased expectations, increased access, catching up in healthcare provisioning. All these will actually lead to rapid increases in demand for healthcare services. But it's not just on the demand side, even on the supply side, we will see pressures on healthcare systems. For example, technology infrastructure drives a lot of the cost increases in high-income countries, and this will also happen in low and middle-income countries. And of course, health financing and payment schemes have a very huge impact on the way that healthcare behavior occurs and the costs to the healthcare system. And finally, I think there's a very important point which is less often discussed, and that is the impact of, if you may like, excessive healthcare workforce specialization. So, for Asia and the rest of the world, there will be much greater pressures on healthcare demand and costs, and these will present great challenges. But on the healthcare specialization side, what this slide illustrates is the situation in the US, and which is also common in many OECD countries. Now, this rather complicated slide shows one major point, which is that in the US over the last decade or two, in nearly all sectors of the economy, as that sector grew, the labor productivity actually increased. So all the bars are pointing to the right. Except for the one shown in yellow, that's the healthcare and social assistance. In the US, as the healthcare sector grew in terms of economic share, in fact, labor productivity became negative. So in fact, more and more people, specialized manpower, are required to provide healthcare for an increasing number of patients. And so if you extrapolate this to Asia, and if Asia were to adopt the same models of health delivery as is present now in the developed countries, one problem is going to be that even if we had the money to do so, we simply won't have enough well-trained healthcare workers to meet the rising demand. Right now, the high-income countries of the world are able to meet the healthcare worker needs because they import healthcare workers, well-trained healthcare workers from countries which are earlier in the development phase. But as the developing countries get more affluent, then they too will need to keep the health workers, and there will be great pressures on healthcare worker supply all around the world. So the way I've spoken about this perhaps implies a certain pessimism about the future. And indeed, public health in Asia will present one of Asia's greatest challenges. But I think it also at the same time offers opportunities for Asia to make big strides in addressing these challenges. And in fact, this could be one of Asia's greatest opportunities. And it can be one of Asia's greatest opportunities because as the rapidly emerging Asian countries grow economically, all of them are going to invest much more resources into their healthcare systems. And the key question therefore is, how should these countries best invest these resources to get the best impact from health? Now, this is a complicated topic, and there are many frameworks to think about this. So I just mentioned one, WHO's framework for action in developing health systems. I don't intend to go through this, but I just want to preface my next few remarks by saying that there are well-established frameworks for developing healthcare systems. So if I step aside from that, I just want to point out to a couple of opportunities for leapfrogging to occur in Asia in relation to public health. And one very important thing which everyone talks about, but which often receives much less attention in terms of policy and action, is to give very high priority to health promotion and disease prevention. And in particular on focusing on behavior change and how this can be effectively done. Well, if we look at most healthcare systems around the world, it's certainly true in Singapore, I suspect it might also be true in India, you'll find that the way clinical medicine is developed has really been centered around clinical medicine, which is the treatment of disease in individual patients. And this is often an institutional-based approach. Now, this is quite understandable because of the dramatic advances in healthcare and medical science, and in terms of our ability to treat more and more advanced disease. But when you have a situation now where the major pressure points on healthcare systems are really coming from massive increases in non-communicable diseases, at the same time, high burdens of infectious diseases in developing countries, this is all going to funnel into a massive rate of increase in demand for clinical medical care. And this will exceed the capacity of even the best resource systems in the future. So for us to really be able to tackle this, we really need to focus on public health, which is promoting health and preventing disease at the population level and not at the level of individual patients. And there are many things that can be spoken about it. In the interest of time, I won't touch on that. I'll just want to point to the critical importance of focusing on changing behavior. Because many of the diseases, in terms of infectious diseases, such as your willingness to go for vaccination, to boil water before drinking and so on, reflect behavior. And behavior is even more important in non-communicable diseases such as diabetes and obesity, where you need to watch your diets, exercise, avoid smoking and so on. Now, a lot of the focus on changing behavior has been on education, telling people that you'll die if you smoke, if you get fat, you get all these diseases. Well, the bulk of the evidence is that doesn't work very well. The people who would respond to such education would have made changes anyway. And the people who are not going to change are not going to pay much attention to just information. So targeting changes at what is called the reflective behavior through public education is of limited value. And there's a lot more interest now in targeting at automatic behavior. If you think about yourselves driving home from work, you're actually engaging automatic behavior because you're not consciously thinking of where to go, you automatically know where to guide your car. And so there's a lot of very interesting work that shows the extent to which our behaviors are determined by subliminal influences. For example, if you have school kids who are watching television and there are a lot of advertisements on fast foods, then in fact they end up eating a lot more fast foods, even the types which are not shown on the TV program, during the program and thereafter. The same is also true for consumption of alcohol in adults. So one can actually target automatic behavior through very simple means. Like if you make the tobacco shop very inaccessible, most people, unless they're really dying for a smoke, would give it up, right? So there are many things that need to be done, research to be done in interventions targeted automatic behavior, and I think that there is something that is worth much further study. Of course, you can also try to change behavior not at the level of the individual, but at the level of whole communities. And tobacco, smoking control is a very good example of this. There's a combination of education, there's prohibition of sale of tobacco, prohibition on smoking in public places, high taxes. So the combination of interventions at the individual and policy level create a framework that actually effectively changes the behavior norm of the entire society. And this might be a model really for other types of well-established threats to public health in terms of behavior. And finally, finance and payments and social activism at the side of the healthcare provider can also push action towards more prevention. For example, if insurance companies were incentivized to reward or to incentivize healthy behaviors, then they can do a lot in terms of the way they set up their payment and co-payment systems. I think beyond that, there is also a lot of scope, and India is a real leader and pioneer in this, in piloting new delivery models that, in a sense, leapfrog the traditional ways of delivering healthcare. And if I come back to this model which I spoke about earlier, a focus on clinical medicine, the truth of the matter is, in clinical medicine, the center of gravity of many healthcare systems is in the treatment of advanced diseases. So highly trained specialists are used to looking at diseases which are highly complex, which have a high degree of variability between patients, and which are high-tech. And these approaches are very intensive in terms of resource requirements, costs, and human manpower. But many of our patients in hospitals today, and this is certainly the case in places like Singapore and other parts of the world, many of our patients in hospitals have non-complex chronic diseases, the diabetes and hypertension that require not high-tech, high-variable types of care, but consistent delivery of well-established measures to control the diseases. And so I think there's one area that we can focus on, which is to develop new models where we can much more effectively and cost-effectively manage these non-complex, non-communicable diseases. And here, again, in the interest of time, I won't go into the different models that have been tried, except to say that the whole area of mobile health looks very promising. For those who are interested, WHO carried out a very interesting survey in 2011 and noted that there are many initiatives being carried out around the world for a wide range of applications, but there are still significant barriers to its widespread adoption in healthcare systems. And the primary impediments to its widespread adoption in healthcare systems is that many are interesting pilots, but they don't tell you whether or not you save money, whether they are more cost effective. In fact, in many cases, they add on costs because the additional interventions are not integrated into existing healthcare delivery systems. So you have the existing system and you layer on a new type of health delivery, and therefore you are in fact increasing the cost of health delivery. And finally, one very critical impediment is the fact that you need much better diagnostic sensor technology, pulse oximeters, blood pressure monitors, but at much lower costs, because this is what you need in order to have it widely deployed. So again, this represents, we think, a very important opportunity for Asia to leapfrog. And just to also note that within this, there's a very critical role for education. Traditionally, medical doctors are trained to work as individuals, looking after individual patients. But we need actually to give them a much broader foundation in public health, in health systems, and in working in teams, so that they would be able, when they graduate, to be much more attuned to systems-based approaches to health promotion and disease management. And finally, I think there's a lot of scope for research which is focused on developing treatments and clinical approaches, as well as health system innovation, which are appropriate for the populations and the contexts of Asia. So, in summary, I want to just say that within the massive changes which are being created by globalization, what is emerging for Asia is that public health is becoming one of its greatest challenges. We remember that Asia is extremely heterogeneous, it's undergoing massive rapid transformation, and all these complex driving forces end up with driving up demand for healthcare and eventually costs. So this will be a very severe challenge for all countries in Asia and in fact throughout the world. But it also represents for Asia perhaps one of its greatest opportunities. Its opportunity to develop systems that really can promote health and prevent disease, to experiment with and to scale up models of delivery which actually provide good care cost effectively and while reducing the number of specialized healthcare workers required. And finally, the critical role that education and research play in this. And I think with that, I would want to congratulate the University of Hyderabad on developing its current public health program and in developing new masters of public health, because I think this will be yet another important contribution to the global effort that needs to be mounted in order for us to collectively address the very serious challenges of public health in our globalized world. So once again, thanks very much indeed for the pleasure and honor of sharing some thoughts with you, and I look forward to hearing your comments, views, and questions. Thank you.
So, don't you need some kind of training right from a very beginning in the school itself, what to be provided where young people or other very young people are get aware of this, because I myself don't smoke and all that, but many times I see young people smoking and all that. It's strange that with all the information available, they are still doing that what they are not supposed to do.
Well, there are many reasons why people do that, and that's because in part it is in part because of the differences in way people perceive risk. So every time you tell a smoker that, well, if you smoke you will die, they will point to Uncle Johnny, who smoked till he was 90 and still is hale and hearty. So there's a question here of depriving yourself a lifetime for a statistical risk of a problem later on. But as I mentioned, it goes beyond education. It actually requires a combination of actions. But what is quite interesting is if you take a comprehensive approach, as I mentioned, education coupled with a lot of work in the schools, preventing smoking, raising taxes, and so on, over time you actually drive the social norm towards one which is non-smoking. And so the hope is that once you do that, then it becomes self-perpetuating. So in Singapore now, the smoking prevalence is about 14%. So it's actually relatively uncommon to see someone smoke in the public. And you will, if you go out and if someone is smoking, you would see people looking at them as if it were something unacceptable. So over time, I think it's possible to drive the social norms towards a non-smoking one. The difficulty is how do you actually get there, and I think you need a combination. I will make one other point, which is that the marketing companies, tobacco companies, fast food companies have been very skillful at portraying the pleasures and the benefits of their products. But the public health officials have been have lagged behind in using the same approaches to highlight the dangers to the general public. And I think therefore we need also to ramp up our sophistication in the understanding of how we help people shape their beliefs towards more healthy behaviors.
Because I believe that in China, large percentage of money.
Yes. And that's because also tobacco companies are being driven there because of tightening of the systems in other countries. Yeah.
Yes, Mr. Raman. Professor Tan. This relates to the policymakers' resistance in countries like India to increase their budgets for public health. I have been noticing documents from international agencies which show India in a poor light as far as public spending on health is concerned. But we also notice large contingents of bureaucrats attending different kinds of training programs. What is that we can learn from Singapore as to how to increase the funding for public health and how to popularize public health curriculum?
I probably don't know enough to comment specifically about the situation in India, but I can say in general that public health often falls behind because compared to clinical medicine, it's much less dramatic. In clinical medicine, I mean, if you show a child with a very complicated leukemia who got saved, people respond to that very instantaneously. It's much harder to explain, if you diet for 20 years and don't smoke, you turn out fine. So quite often the pressing priorities push delivery of clinical medicine to the front. And in a constrained budget situation, it often means in many countries that less money is spent on public health. I think there are many ways in which we should work together to address this. The first is really for medical schools and universities to further strengthen the database, the evidence base, to show effectiveness. If you think about the situation in smoking, what was particularly influential in the prohibition of smoking in open spaces was the demonstration that secondhand smoke was deleterious to other people. So in other words, you're not just harming yourself, you're harming everyone around you. And therefore, it provided the rationale for prohibiting smoking on the basis that your activity is harming everybody else. So we need to constantly strengthen the clinical and evidence base so that the policymakers have a good basis in science to inform their decisions. Take, for example, the whole area of mobile health. It seems very intuitive that if you can do all these things through telephones and all that, it must be very good. But we don't really know whether it's very good. And so we actually need to mount rigorous studies, demonstrate that, in fact, it delivers good outcomes, clinical outcomes, and is much more cost effective. So that we will not just convince politicians, but convince the general public, because the general public might see all this as a cost-cutting exercise. They rather go and see a physical person, a physical doctor, rather than talk to someone on the phone. So this, I think, is necessary. And I think the third part is really the involvement of the general public. And again, the general public, I think, have an important role in helping to drive change, because beyond the government, there are a lot of opportunities for civic types of activities which will promote public health and have a much greater impact on specific communities. So in other words, I think we need to take a multi-tiered approach to doing this. It is something which is present in most countries of the world, and we need to constantly argue the reasons, the logical reasons for why greater investments in public health will pay off in a much greater way.
Go ahead. So actually, regarding the migratory population in South Asian countries, like most of the people from the village backgrounds, they are migrating towards urban cities or nearby towns. Like in these people, the more workforce is getting into stress. Due to this stress, people are suffering from so many psychological disorders and also physical disorders and psychosomatic disorders. And due to which the mortality rate also every day is increasing due to globalization. How can we prevent the? How can we use the effective public health policies to prevent this mortality rate and increasing the psychosomatic and psychological problems in the migrated population?
Oh, you raised a very good point which I didn't touch on, which is mental disease. And in fact, mental disease is one of the largest contributors to the burden of disease globally. And certainly in some countries, for example, suicides among young people is one of the highest causes of death. I think the main point I want to make in my presentation is that many of these issues are not public health issues alone, and that they're not things which are just for public health officials to deal with. They in fact rely on a lot of other agencies, ministries that deal with things such as economic development, social policy, housing, provision of sanitation, local services, and public health. And therefore, you actually need a much more integrated approach in order to tackle a problem like this. And yes, public health officials can go there and mitigate some of the issues, but will not be able to address some of the root causes that lead to these problems. And therefore, you actually need a much more concerted effort at a whole government level.
Actually, I was really happy to note that you pointed to behavior change as one of the major spokes that we need to tackle public health. But when you're looking at changing social norms, if you're looking at a fairly homogeneous population, you know what the existing social norms are. They're fairly universal and you can target them to change them. But when you're looking at a country like India, and I'm sure many other countries like this, you have a variety of social norms. So how does a public health campaign that aims to change behavior through the changing of social norms even begin to address that? I mean, we seem to be able to do it in a piecemeal approach, but when you're looking at big problems, we just seem to get defeated by just the layers of social norms that we have to do.
It's a very good point, and I would say that the most effective interventions are the comprehensive ones, like cigarette smoking, where you're not just targeting actions on individuals, you are really taking a series of actions which will change the behavior of the entire society or community. So regardless of what your cultural beliefs are and so on, I mean, a tax on cigarettes is a tax on cigarettes. Prohibition of smoking in an open space is a prohibition. So I think those are probably the most effective ones, but unfortunately the data evidence base for these interventions that justify these interventions is not so great for so many conditions that can be applied. I think if you look at Mayor Bloomberg in New York, I mean, he's extending it to excessive consumption of sugar, trans fats, and so on. So I think this is one way in which we can address that. But I think there's a more general issue, which is a very important one. It goes beyond cultures, and that is now with the pervasive presence of social media. How do people actually form beliefs? And quite often they are actually formed more by peer-to-peer information as opposed to authority-to-person type of action. So, in other words, we actually need to think much more deeply and do a lot more research into how we get across our messages in ways which will transmit much more effectively. And here, there's some interesting work in other areas related to marketing. that show the influence of peer influences. And in every distribution of people, there are some people who are more influential than others. Their views carry a lot more weight. And peer influences, whether through social media or through face-to-face interaction, can have a disproportionate impact on the spreading and adoption of certain norms. So I think this will be an important area that we need to understand better in the future. The literature on it in terms of cross-cultural influences is still very sparse, so I don't have an answer to your question, but it certainly is an important area to study. And what it underscores is the need for cross-cultural comparative studies, because behavior intervention which work in one community might fail in another.
Sir, in India, the software industry executives, they work in the night shift. So there are some of the shift workers in the industry also. So for such people, it is a forceful employment, and they have to change over their living style, by which they are getting this non-communicable diseases, hypertension, and this stress disorders also. So what is your role model, a working model for such people? They have to work, and how to get rid of this the non-communicable diseases. And this is the modern, as per the WHO, they say that you should have the mental health as well as physical health. And as a medical scientist, you have touched many areas. You have taken the coin of public health, but the role of the private organizations, or the private people, or the public procedures and the government responsibility, can you please give in Indian scenario? And there is no difference in Singapore. It is all similar. A great lecture you have given.
Thank you. So I think on the shift workers, it will depend very much on the particulars of the area, but I think the general approaches remain the same. But the point you make about the government not being the only player, should not be the only player, is a very important one. And the government actually needs to set up the regulatory framework and create the environment where other players can come in a hopefully more coordinated manner in order to do things in a community. And so there's a lot of scope for not just NGOs, private companies to participate, but actually also a much more peer-to-peer interaction. I think in the future we will see some models of health delivery or intervention that involve much more peer-to-peer. In the UK, for example, there's a very interesting trial where palliative care for advanced cancer patients is given not by well-trained oncology nurses, but by volunteers in the community that had 3 weeks of training. And they were able to show that such individuals were able to provide the majority of needs of advanced cancer patients. So in the future, the scope for involvement would extend beyond actually organizations right into individuals within communities. And this way of getting a more inclusive participation might provide avenues to provide much better care without having to have more and more highly trained specialists.
Take one last question here.
Just as an observation, do you think public health practice is more feasible in egalitarian societies and non-societies? Also, what is the role of public health education, like including courses like public health, masters curriculum, or public health leadership courses for clinicians? Would that be of some help?
So I don't particularly think that it's a function of your stage of development, because certainly the opportunities for doing things in countries earlier in the development phase are actually very huge. And so I think that the public health involvement does not quite depend on that. In terms of training, that is a very critical part of it, and training should extend clearly to individuals who are going to be public health officials, but it's actually also very important if you can bring in policymakers, people in finance, for example, or health ministries, NGOs, to have either formal public health training or short courses, because this is a multi-sectoral effort. And if individuals in decisions or influence understand the goals and rationale, some of the basic precepts of public health, then they would be better placed in order to work with others in order to implement these programs effectively. So in NUS example, we do have a number of initiatives that try to spread out training in public health to individuals beyond just people who are strictly in ministries of health.
Okay, one absolutely last question.
Sir, I just have a point to make. When you said that the solution to all this is behavioral change that we should bring, I think in India already public health poor personals are there are trying to get the behavioral change using the adulation or religion. People use celebrities to endorse certain health aspect they want to make sure that suppose vaccinations or any health aspect, people use celebrities, the adulation for celebrities, that if they make a statement, people will follow it blindly. Or making behavioral change can be done through religion. If your religion priest or somebody preaches that you should do this or you shouldn't do that, people will follow it blindly. So when you said that scientific evidence should be given more to the policymakers so that they can show that and get funds and then influence people in making a behavioral change, I feel that wouldn't help because people are either inclined towards persons whom they like or the religion in which they have a blind faith. So either way.
Yeah. It's a fair point. Goes back to the heterogeneity of the populations we deal with. So there's a distribution of different communities, and adulation and blind compliance might work for some segments. It probably will not work for other segments. And therefore, I think what I'm advocating first is I'm not saying that behavior research and intervention is the solution. I'm saying it's an important, critical contributor to us resolving issues. Increasing the base of our understanding of how people form their beliefs. Even somebody who is just following because a pop star does it, but why does a person do that? If we are able to understand that, then we will be able to better craft ways to reach out more effectively to these individuals. And finally, of course, there's also what are the correct behaviors to be adopting, right? Those of us who are trying to live longer by eating healthily, we are forever dismayed because one week coconut is bad, next week coconut is good, chocolates are good and chocolates are bad, So that database itself causes a lot of confusion, and so we too have a role to play in trying to summarize the best evidence so that our celebrities hopefully give the appropriate advice.
Okay, I just want to add a comment to what just mentioned. See, the corporate sector is also involved in changing behavior. Right?
Yes.
So, how does one resist? Don't you think that they should also make public health issues as part of the corporate social responsibility?
Yes, right? yes, indeed. Indeed, and we saw that with cigarette smoking, where in fact the revelation of the strategies of the big tobacco companies to deny the evidence and to take court cases in order to derail, I think opened the eyes of the public to the fact that these things were going on. So I think the public expectations can play a very important role in shaping the behavior of companies. If everyone in Singapore just ate things which were free of trans fats, then of course the companies will respond to that. So we as consumers actually can play a very important role in helping to shape the way companies behave through the expectations that we articulate and through the choices we make in what we buy. And again, it's a question of how do we do this in a more systematic manner, in a scalable manner, and a manner that after a number of years intervention, we will see steady progress and good gains in the major areas. And I think focus is required there. Focus is required and a systematic approach is required in order to seriously tackle these issues.
Thank you.